Right? Not sure what happened there, but so it's my pleasure to introduce Dr. Phillip Bonney this morning. He is a neurotrauma fellow at UCSF in San Francisco. And for those that don't know, this is kind of like the mecca of neurotrauma with Dr. Jeff Manley as his mentor, who is the head PI of Track TBI. Phillip Bonney got his BS at the University of Tulsa and eventually did his neurosurgery residency at USC in Los Angeles, and as I mentioned, is now in San Francisco. He's going to be talking to us about a very hot topic in traumatic brain injury, and probably one of the areas that is going to guide us forward with new classifications and prognosis, and potentially, help guide our treatments, and that is biomarkers for traumatic brain injury. So, without further ado, I will hand it over to Phil to take us through this. Thanks, Phil.
Great. Thanks so much for the introduction. Thanks for having me this morning. Let me share my slides here. Okay. It's nice and early here in San Francisco. Again, it's a pleasure to be here talking about biomarkers across the spectrum of TBI. No disclosures. I did make several of the figures for this talk using DALL-E 2, which I think will date this talk very soon as these technologies improve very rapidly in AI image generation. A shout out to Patrick Reed, who's a good friend and mentor. Patrick was a chief resident when I was an intern at USC, and has been very helpful to me throughout my career, both in neurosurgery and in life in general. I'll briefly start by introducing biomarkers. I'm not going to get into the basic science of biomarkers in this talk, but I will kind of talk about where they come from. So a biomarker in general is something that can be used as a marker of health or disease. The biomarkers in brain injury that I'll be talking about today are proteins which are released from injured brain tissue, which end up in the blood. Some biomarkers are also used in CSF in certain instances, but for TBI, blood biomarkers are what's used. The most common ones here I've underlined, which I'll be talking about in this talk, which include GFAP and S100 beta, which are from astrocytes, and then UCHL1, NFL, and NSE, which are from neurons. And then a little bit about the time course of biomarkers. There are biomarkers which have been used in different periods of injury. So in the acute phase, UCHL1, GFAP, S100 beta, and NSE have been used. Later on, NFL and tau have been used more throughout the variety of responses to a TBI that occur up to months and years after injury. So I'm going to frame the conversation about biomarkers with respect to where we are with our standard of care of treatment in TBI, and talk about areas for improvement using biomarkers. I'm going to start with diagnosis. The best use case for biomarkers right now in TBI is to rule out the need for a head CT in patients with mild TBI in the emergency room. So a number of studies have led up to this point, but one of the most important ones was published in 2018. It was an observational study of 2,000 patients called the ALERT TBI study. There were 22 centers, 15 of which were in the United States. For this study, it was patients who were going to get a CAT scan anyway, and then GFAP and UCHL1 labs were drawn prior to CT, both of which were within 12 hours of injury. They used pre-specified cutoffs for their biomarkers based on prior work. And from these tests, a third of patients were negative on both tests, and then a fourth were positive on both. And then the remainder were positive on one or the other or had an invalid test. The criteria for inclusion were a GCS 9 to 15, but the overwhelming majority of patients were GCS 15, 93%, and then 5% were GCS 14. So almost entirely mild TBI. I'll talk about this in a bit, but the false negative patients are shown here with their scans, and I'll come back to that. So here are the results from that study. Just kind of going through the table here, 42% of patients had loss of consciousness, 33% had post-traumatic amnesia, 21% had intoxication with alcohol or drugs. Only 6% of the scans in the study were positive, which is a total of 113 scans with traumatic injuries. In terms of when the labs were drawn, this becomes important in comparison to some of the track studies. It was very fast. The median time from injury to blood draw was 3 hours with an interquartile range of 2 to 4 hours. I'll talk in a bit about why that may be important. The median GFAP value was 24. Their cutoff was 22 for a positive test. You can see the scatter and positive the scatter and GFAP values based on if the CT scan was positive or negative. The authors stratified by all patients, which are the black dots, and the mild TBI patients in the red dots. It's essentially the same population because 98% were GCS 14 or 15. You can see here that the median value for GFAP in positive scans was higher than for the negative scans. The median for positive was about 130 and is 22 for negative scans. The UCHL1, the overall median was 270 and the median in positive scans was 600. And in the negative scans, it was about 260. So using their pre-specified cutoffs, they showed a negative predictive value of 99.5%, which is out of 600 patients who tested negative on both tests, there were 3 with positive CT scans. And I'll just go back and show 1 traumatic subarachnoid here. 2, this is actually a cab mount on MRI that followed, but for the purposes of their criteria was defined as a positive scan, and then 3, a convexity subdural. So a very high performing test. The positive predictive value here is only about 9%, which is, again, the goal from the test is to rule out the need for a CAT scan. It's not trying to predict positive findings on a CT as much. I mentioned previously the time course of blood draw. That may be important, especially for these very early draws. Here's a study looking at patients with serial GFAP and UCHL1 values. So labs are drawn every 4 hours for 24 hours and every 12 hours after that for up to a week. And what I want to show here is the elevation. So a peak for GFAP, which overall is the most useful biomarker that we have, was about 16 to 20 hours, depending on the subset of patients. And at 4 hours, you can see that it's only about a fourth or a fifth of the maximal value. So that may be pertinent within the first 24 hours, the timing of the blood draw may be relevant in some of these studies in a way that has been incompletely characterized so far. One of the track studies is here. The innovation with this study was using a point of care assay for the biomarker test. So the study compared GFAP to S100 beta. in a subset of patients. The time to blood draw here was more than 13 hours. So you can compare that to the previous study where it was a median of 3 hours. And what the track investigators showed is that GFAP outperforms S100 beta. The ROC curve is shown here with area under the curve of 0.85 for GFAP and 0.67 for S100 beta. The values for GFAP based on CT findings are shown here. So subarachnoid hemorrhage, subdural hemorrhage, contusion, and then combinations of these showing elevations over negative head CTs. And so they showed that at a cutoff of about 35, the negative predictive value was 95%. Which led to the FDA clearing the Abbott test for use. So this is an ISTAT test that can give results in 15 minutes, which is coming online now. And the value for that, again, is 35 to rule out the need for a CT scan. In patients with mild TBI with GCS 13 to 15 presenting within 12 hours of injury. So the goal of these biomarkers in the ER would be to reduce unneeded head CTs after mild TBI, which in spite of clinical rules for identifying who needs a head CT, still head CTs are overused in the emergency room. And this has been shown by a number of authors. One study which was published last year, which is very interesting, is a comparison of these clinical rules, the New Orleans criteria, the Canadian CT head rule, and Nexus to biomarkers and evaluating patients who do not need a head CT. And it's interesting. What they showed is actually both the clinical rules and the biomarkers were very effective. The negative predictive value of the clinical rules was 100%, 100%, and 98%. And for the biomarkers was for various cutoffs of GFAP and UCHL1 was 98%, 97%, 97%. So I'm only showing one of the two cutoffs used in the study here, but they were both fairly similar. So what these data suggest is that if these clinical rules were used, that it's unclear that there would be an absolute need for biomarkers, but in fact, of having done the study, they're showing that these rules are not being used that closely in the ER, and an interesting survey was done for the ER physicians in the study, which was asking how comfortable they felt using the clinical rules, and about 40% were either unsure or not comfortable with these rules. And when asked if they use the rules, it was only a small fraction that were using the rules in their practice, which I think the objectivity of these biomarkers will improve the use in clinical practice and hopefully reduce the need for head CTs. I'll briefly mention safe harbors. A safe harbor is a protection that serves as a legal standard of care where if it's enacted, a provider cannot be sued for malpractice. So safe harbors is something that is coming into the conversation now to protect physicians and to decrease waste and resources. So these investigators from Vanderbilt talk about 3 safe harbors: low back pain, headache, and mild TBI. Essentially, a safe harbor needs 3 characteristics. They need to be announced in advance. They need to be narrowly conceived and highly targeted, So juries and courts cannot second guess the appropriateness of the clinician's actions. And 3, carry the force of law and constitute the legal standard of care. And I think biomarkers could potentially have a role in defining a safe harbor for mild TBI so that ER physicians feel empowered to not overutilize CT scans. So I was talking about a test to rule out the need for a head CT, but what if we could use biomarkers to diagnose TBI? So it would be a positive test would help us to say that a person has had a TBI. We know that mild TBI patients who have negative head CTs can still be have severe impairments from their TBI. This has been shown in several track studies recently, showing poor cognitive outcomes and a high rate of symptoms even at 6 months. So in the study of 991 participants with TBI with GCS 15 and a negative head CT, 56% in incomplete recovery at 6 months. And I think as a neurosurgeon, these patients are kind of invisible to me, and they comprise the vast majority of TBI, and it's kind of an understudied population because, again, they're not presenting in the healthcare system as having acute needs if their head CT is negative. I'm going to briefly talk about the diagnosis of TBI. I think it's very complex, and what I'm trying to highlight here is the need for improved diagnostic modalities. So just kind of talking about the definitions of TBI. The World Health Organization definition says a TBI is an acute brain injury resulting from a mechanical injury to the head from external physical forces, excluding manifestations related to drugs, alcohol, medications caused by other injuries, or treatment for other injuries caused by other problems, or caused by penetrating injury. It's a very broad definition. And then the NINDS definition says that TBI is defined as an alteration in brain function or other evidence of brain pathology caused by an external force, which is also kind of vague. The ACRM diagnosis is the most specific, but it's actually fairly complex. I'm just going to walk through it here. So first, you have to have a mechanism of injury, which includes a head strike, acceleration, deceleration event, or a blast force. From there, if you have a positive imaging study, then you can be diagnosed. If you have one or more clinical signs, which include loss of consciousness, alteration of consciousness, post-traumatic amnesia, or seizure, you can be diagnosed as long as the findings are not better accounted for by a confounding factor. And then in the middle here, you can have a combination of symptoms and clinical exam and lab findings. These symptoms, you need 2 or more of a variety shown down here, everything from headache to feeling disoriented to a difficulty with concentration, etc. And then the clinical exam findings include cognitive impairment, balance impairment, oculomotor impairment, and then they've added biomarkers actually in here, although don't have cutoffs shown in this table for the diagnosis. So if there are confounding factors, or if not all criteria are met, you can still end up with a suspected diagnosis, but that's a separate pathway over here. So what I'm trying to show again here is that it's actually quite complex to diagnose TBI, and there are a number of instances in which these criteria are hard to meet because of either a confounding factor or overlapping syndromes. And so the question is whether we can use biomarkers for TBI the way that troponin is used for a heart attack as an aid in diagnosis. Here's some data from track showing GFAP and UCHL1 comparing TBI patients to ortho controls showing excellent performance with the area under the curve for GFAP of 0.91 and not really adding much here with UCHL1. I think this could be important going forward. It continues to be a big problem in the emergency room of actually attaining a diagnosis of mild TBI in patients who either don't have a CT scan or have a negative CT scan. So this study was a review of TBI patients in the ER or potentially TBI patients in the ER who met ACRM criteria for TBI with a negative head CT, and actually 53% of people who would be classified as mild TBI by ACRM criteria were not diagnosed with TBI prior to discharge, which I think highlights this problem in the emergency room. I'm going to briefly talk about concussion. I think that there is interest in having a biomarker test for concussion, either for return to play in the same event or returning to play after a concussion protocol. I'm just showing some guidelines here for returning to play, and one set of guidelines. A player can go back into the game if there's no loss of consciousness and the symptoms last for fewer than 15 minutes. And then some of the other guidelines, if there's any symptoms at all, a player cannot return to the game. So I think this kind of highlights the potential use of an objective test for coming into the game. Just kind of going through some of the tools used to diagnose concussion on the sidelines. A number have been used. The SCAT's the most common. We're currently on the SCAT-6, which uses a variety of tests, starting with some red flags. And if there's no red flags, then a more detailed a series of questions and exam that's performed for evaluation of concussion. And here's the NFL protocol, very brightly colored set of forms here to kind of walk through what happens for a sidelines evaluation of a player. There have been several studies of biomarkers in athletes. Here's one in NCAA athletes who had concussion compared to contact sport controls and non-contact sport controls. In the left graph, in the yellow, are athletes who had concussion with loss of consciousness or post-traumatic amnesia, and in the blue is those without loss of consciousness or post-traumatic amnesia compared to controls. So you do see an increase in GFAP in the acute setting after a concussion. The time to blood draw after these concussions was about 3 hours. So you know, you have to kind of take it with a grain of salt here for the acute phase, especially when we're talking about using on the sidelines. And then the receiver operator characteristic curves are shown here, comparing those with loss of consciousness or PTA to contact sport controls in the acute phase. You know, unfortunately, what we really want to see here is those without loss of consciousness or post-traumatic amnesia compared to controls, if that's how we're going to be using the test. You know, for those with more severe findings, they're not going back into the game no matter what. And it would be those with uncertain findings and kind of unclear symptoms, if they can go out into the game. So I don't think we're there yet, but it's an area of interest in the future. So far we've talked about who needs a head CT, when can athletes return to play, within the diagnosis of TBI, questions like, you know, time off work and time out of class. And then what I want to talk about now is referral to TBI clinic for those with a diagnosis of TBI. This is something that we are focused on here and have been doing it for about 6 months. a multidisciplinary TBI clinic, including neurosurgery, neurology, neuropsychology, and a variety of therapists, speech therapists, physical therapists, occupational therapists, trying to meet the needs of a TBI patient, which are very complex. There's not a great model for this. We're trying to pilot a model and a system of care that can be scaled, but the needs which have not been met by the American healthcare system for TBI patients include an understanding of TBI for these patients through education, prognostication about symptoms, actual treatment of symptoms, which are many after concussion and TBI, and then guidelines for getting back to activities and many more. The majority of patients who have TBI do not present to the emergency room, to the acute healthcare setting, and instead present to primary care. Here's a study in kids out of CHOP, which showed that about 80% of kids enter the healthcare system after concussion through their pediatrician. So some uses of biomarkers in a TBI clinic in the outpatient setting could still be diagnosis if they've not been diagnosed previously. If this is a track study showing that biomarkers can be used to diagnose up to 2 weeks after an injury. So in the red here are CT positive patients. The yellow is CT negative patients who are diagnosed with TBI, and then the blue is ortho controls. And then in this bottom table here to show the area under the curve for a variety of for 3 age groups at days 1, 3, 5, and 14. Another thing which is a factor in the care after a TBI would be the question of whether or not to get an MRI, and biomarkers can help predict positive findings on MRI scans after TBI. So here's a large track study which showed a fairly good performance for GFAP in predicting MRI positive findings in those who had negative head CTs. These MRIs were done 1 to 2 weeks after an injury, and 25% of patients who had a negative head CT were positive on MRI, which just kind of shows that a lot of these injuries are subtle. The values of GFAP by diagnosis on the MRI are shown here. Traumatic axonal injury is 1 to 3 petechial hemorrhages. Diffuse axonal injury is more than 3 petechial hemorrhages. And then the median values of GFAP for each category of patients is here. So the median for positive head CT patients is about 800. For those with a negative head CT and a positive MRI, it's about 400. And then for a negative head CT and a negative MRI is 74. Compare that to ortho controls with a median of 13 and healthy controls with 8. In that same study, several other biomarkers were looked at, just to show here that GFAP tends to be the highest performing biomarker in TBI. So UCHL1, S100 beta, and NSE were not useful in this prediction of positive MRI findings. Some early work which is interesting is correlating biomarkers to MRI findings in the subacute and chronic phase of TBI. Here's a recent study which looked at values of GFAP and NFL in patients about 8 months out from TBI. And an interesting correlation here between the NFL value at 8 months and subsequent volume loss on MRI scan up to 5 years out from injury. And then correlations are shown here between the biomarkers and various MRI characteristics. So I'll briefly talk about treatment of TBI, and we still have a lot to learn about the best treatment of TBI patients. I think part of that is understanding the different types of TBI patients. So far with GCS, we have kind of lumped patients into a very broad category of severe TBI, and our treatments have not often proved to be effective, which may be an issue of understanding how patients are different. So what I have here is the guidelines for the management of severe TBI, the 4th edition BTF guidelines, which unfortunately have not shown a lot of things to be helpful. One of the main takeaways I take from this is that a hemicraniectomy is better than a pterional for TBI, and that there's not much more beyond that, unfortunately. We do have some prognostication models for severe TBI, and I think biomarkers will help us a lot here. So I have the crash and impact model calculators here, which can be used to predict the risk of death or unfavorable outcome after TBI with a variety of inputs which are known at the time of injury. So here's some biomarker data in prognostication. This is a track TBI study which looked at GFAP and UCHL1 at predicting outcome at 6 months based on a GOSE. And on the left panels here are GFAP, and on the right panels are UCHL1. And then on the x-axis here is GOSE going from 1 to 8. 1 is death, 8 is a complete recovery, and then GFAP values on a log scale here. The blue is all patients, the dark orange is severe and moderate TBI, and then the lighter orange is mild TBI, showing that you do see some prediction here with lower GFAP values for the better GOSE scores. And then if you take quintiles of GFAP values into a survival curve, survival curves for each quintile, you do see excellent prediction with the highest quintile of GFAP and pretty good spread for each of the quintiles. And the same can be said for UCHL1. So these, when added into prognostic tools which already exist, improve the prediction. So this is a comparison of the impact model with and without the biomarkers. And so the area on the curve without the biomarkers at prediction is 0.78 for unfavorable outcome, and when adding the biomarkers improves to 0.86, and the R-squared for the model improves from 0.31 to 0.5. Same for mortality, improving the area on the curve from 0.85 to 0.92, and the R-squared from 0.42 to 0.61. So a good improvement of existing models using biomarkers. Our colleagues in Europe have done the same thing with slightly different colors in their graphs and using more biomarkers, but have also shown the additional benefit in prediction using biomarkers. So biomarkers have some limitations, but I think that they are still quite valuable and will continue to be explored in a variety of settings in TBI and become standard of care in TBI practice, which gets to a broader goal of better characterizing TBI patients beyond just the GCS into a category based on their GCS, but also what the scan shows and also what their biomarkers show. I'll briefly talk about imaging in TBI patients. I think that's part of this a better understanding of TBI patients. I have the Marshall scale shown here, which is from 1991, which is still somehow basically standard of care for evaluating CTs in trauma patients. You can see the figures here and how far we've come in technology. I find this figure here particularly interesting. There's a fairly normal looking CT here, although quite grainy, and then a ventric has been done here, and these arrows are pointing to a subdural, which I can't see without the arrows, but this looks like an iatrogenic subdural hematoma from the EVD to me, which I find interesting to be in this paper. And then, here's an example also from the paper just of a lot of streak artifact in the head CT. And I think that we can do better than the Marshall classification, and I think it's overdue. So in sum, I think using biomarkers with the other data will help to better phenotype TBI patients and help us to understand specific pathologies better and help improve our treatments. Thanks so much. I'd be happy to take any questions.
Awesome. Thank you, Dr. Bonney, and thank you for getting up so early and presenting. And
oh, sorry, I don't think I'm able to hear you. I'm not sure if that's on my end or yours.
Might be your end. I'm off of mute, so you should be able to hear me. Can you hear us now?
I can hear you fine.
Can you hear me now? No?
One sec.
Okay.
Maggie, are you able to hear Dr. Hickman?
Yes, I can hear him fine. I can hear everybody. Can you hear me?
I can hear you, Maggie. I don't think Phil can. Can you, let me just see if you can, I'll text him or see if he can, I can put the questions in the chat here. See.
I hope you are able to hear me. I'm not sure why I can't hear you now.
Yeah, we can hear you. Here, I'll put, so one of our PAs here, one of our neurosurgery PAs had a question that I've texted you, but just I'll relay to the group. The question is whether or not biomarkers could be used instead of head CT or lumbar puncture and other disease states.
The biomarkers have been used in other neurologic conditions. I know that they have been used in stroke and in a variety of neurodegenerative conditions. I'm not sure about spontaneous subarachnoid hemorrhage. I would say very unlikely to be diagnostic of something with a positive finding. So it's a lot better at ruling out the need for a CT. But it would not be good for diagnosis. So I would say that CT or LP would remain the standard of care for subarachnoid hemorrhage. Yes, there can be false positives in seizures and some other conditions.
So one of the questions that I have that I've sent to everyone is trying to diagnose patients with polytrauma with a concomitant head injury that are comatose from their general trauma. It's sometimes hypotensive or might have confounding factors. sedation, whatnot.
Yeah, sorry, I don't know why I could hear you at the start of this talk and then stop being able to hear you, but I can hear you now.
Okay.
Very strange. Yes, I think that will be very helpful. And I think could potentially predict, you know, if we need to do ICP monitoring, or if we need to take someone to the OR, if you know, the biomarker can exactly be used in cases with confounders, polytrauma or intoxication or something, and help us figure out what's going on a little better.
Yeah, I'm not sure what the population's like there in San Francisco, but here we have a very high percentage of patients with acute alcohol intoxication, like 40–50%. And that, so I think particularly locally, that's where we're probably going to be focusing on biomarkers initially, would be those patients that come in where we have to figure out, is it intoxication or is it, you know, a concomitant head trauma, and, you know, our RED, probably like your ED is like completely full all the time, so they have to prioritize CT to get.
That's right.
But then I think that would, another patient population would be, you know, these patients where we're, you know, they either have been hypotensive or they just got intubated or whatnot, and they have a polytrauma, and you get a head CT and the head CT looks okay, and you're kind of like, now do I do an invasive procedure on this patient? Do I let them wake up or see if they wake up? You know, what's going on? And I think if we had a biomarker that at least could rule out with a high, you know, high predictive value.
Right. Yeah. I think it would probably be harder to do that study because so much of it is a judgment call, you know, compared to these yes, no, with the objective CT findings. But I think it'd be very important and sort of subjective, you know, our own use on a case-by-case basis.
Yeah. I was just also wondering, in patients, I would assume this is the case, although I'm not sure, if patients with concomitant spinal cord injury, if that would confound the biomarkers. I would think so, but I'm not.
Yes. So I'm not as familiar with the work in spinal cord injury, but I know there is an increase. I think that's been done more with CSF studies, but I think it probably will get a little hairy when, you know, talking about multiple injury sites.
Anybody else with any other questions? Let me just put up, just to remind everybody that if you didn't do it yet, if you missed the first screen before logging in, you can log your CME by texting 4966 to this number. And thank you, Dr. Bonney. I appreciate it. Thanks for coming on so early in the morning and giving us an excellent overview of TBI biomarkers.
Yeah, thanks so much for having me. Take care.
And I'll put the link up in the chat for those that want to go to our YouTube site afterwards, and you can look at all of our previous conferences there, and this one should be up there within the week as well. Right. Thanks, everyone.
Thanks.